And here we go.
Oh, yeah.
Episode 7?
Episode 7, Two Guys on a Bench.
Oh, are we sticking with that name?
Yes.
I guess we have to now.
Yes.
So in the comments, if you have a better name, please.
You don't.
We don't.
Yeah.
That's not our thing. So last time, why don't you recap us?
Yeah, so we talked about what manual therapy techniques we like. Soft
Specifically
tissue.
soft tissue,
Soft tissue and joint techniques.
Yes.
So we kind of used the example of the classic, let's just take it even further. Here's your classic example. I slept funny on my neck. I woke up the next day and I couldn't turn it one way. It felt terrible, usually at the base of the neck or maybe the middle of the neck right there. Feels like it's frozen. I am scared to move because it hurts brutally bad.
Mm-hmm.
So on day one,
Let's
what would you do with them? What was, as a recap, with that person, what'd you do?
first of all, rule out ridiculous symptoms.
No doubt.
A lot of evidence says that then if you do some joint thrusts or manipulations, whatever you want to call them,
Yep.
maybe a little soft tissue work to allow that joint to move.
Love it.
Because anytime there is pain in a joint, body naturally will kind of protect it, so it limits muscle activity, both in terms of strength and speed around that joint.
Yep.
Because that's the brain's way of sitting there going, dummy,
Yep.
like stop doing that.
Don't do that.
So we assume we use all the stuff we talked about last time to get
Yeah.
them out of acute pain.
Definitely.
Maybe it's just kind of dull and nagging now, but it's certainly not threatening.
Sure.
So now we have to figure out a way to convince the patient that they should do stuff and figure out the best stuff for them to do.
All right, cool.
So that's usually 3/4 of the battle.
Yeah, definitely.
3/4 of the battle.
All right, so let's say that the same, patient came in and they are now like not, to the left. Now they've got a good amount of, maybe pretty close to what's normal motion. What are you going to do next? And maybe I'll add to that a little bit in terms of how I would do something a little different.
I'm a huge fan of progressions.
Yeah.
Which I feel is always a hard thing to get across to people, where it's like, I don't want you to just do this for forever. It's like, there's stuff coming after that. This is step 1. We're going to take you through step wherever you need to get off the train.
Yeah, no doubt.
So usually with subacute neck people are out of acute pain, but they're still having some issues. I like to start with people in supine. So
Yep.
laying on their back, head supported. We've eliminated the stability requirements of a lot of the cervical spine, so now they can just focus on motion.
Love it.
So make sure they got some motion first. You can throw in some isometrics,
Yep.
where they're just using that muscle tension but not actually moving joints.
Good evidence for that.
Isometrics, are getting a good rep for analgesic effects now.
Absolutely.
So, once they've got that gives them a little confidence. They're like, oh, I can move it and it's not bad. And then you get them up in sitting and you basically have them do very similar things, active range, maybe some isometrics. If they want to get really fancy, they can do some concentric, eccentric type work. You can grab the towel or the band and have them do some of that there. And once they have generally full range and it's not really painful, a lot of muscle activation, then I sit there and say to myself, well, it's probably time to load this sucker.
Yep.
Because classic, personal training, strength conditioning 101 is if you can get a muscle stronger, it can activate at a sub-maximal strength for a longer period of time.
Yeah, so don't need to fire all the way the entire time.
Like if you can do, because as a shout out to my friend John who left, if you can do a bicep curl with 200 pounds once, you can probably do a bicep curl with 100 pounds many, many more times.
Absolutely.
And our neck doesn't have to perform a lot of muscular tension all at once. Like I'm not trying to headbutt someone like this. It just has to stick around there for hours and hours and hours.
Yeah, definitely.
So maybe some farmer's carries, maybe some overhead carries, depending on how much upper trap stuff there is.
Yep.
But just get them to have to be stable for a longer period of time.
Yeah, and I would agree that I would do all that stuff progressively, get them on the table. I think keeping it, the older I get, the more simple I think I keep things. It's like a chef. You don't need 100,000 ingredients to make a good dish. You just need 4 or 5 good kind of quality things. Good education, good explanation, I think is the most important part. I've probably gotten away from doing, I think we always thought like we needed to do all this, shoulder stuff and postural stuff and upper back cuff strengthening or whatever to theoretically, deep neck flexor.
I think you came up at a time a little bit before me.
Yeah.
Where I think that was very much the rage.
It's
Shoulder
kind of
down and back, shoulder down and back.
Yeah, and then we got these people that are all overextended and they come in with back pain the next visit, And honestly, a lot of times people just aren't very fit through there anyways, through that girdle. So especially when they're in pain, you feel like it's a low level exercise, yet they just do a little bit of this, and before you know it, they're getting upper trappy, and they say, oh man, I'm feeling good, that's magic, that's awesome, you know what you're doing. And now like, oh, my neck's feeling a little bit tight, which, if that happens, I'll just say, hey, you're using it for the first time. Now that you tweaked it, it's all good. But I think down deep, we probably know we don't want too much of that too. So something like a farmer's carry is beautiful because they're not really going to, cheat up top. Just keep it kind of medium weight to heavy and let them hang out in a good posture down low, and then, kind of get it and go.
Have to be stable.
Yeah, and I would say too that I definitely like them to just, relax, use a lot of deep breathing to kind of keep the neck turned off as best we can, and to kind of get some good thoracic rotation, extension. We all know different good exercises, for that. So I think if we're going to smash the T-spine and crack it and manip it and do all that good stuff, we should probably give a little mobilization or, range of motion work to the thoracic spine too, for sure.
Restore normal range of motion.
Sure.
For whoever that is.
Definitely.
And then make sure they can control it.
Yeah, absolutely.
Which, you have to do something slow before you can do something quickly with control.
Yeah.
So, before you go and you start doing a bunch of athletic stuff, inverted handstands, all that stuff, you should be able to carry some things.
Yeah.
Which is something I talk to a lot with my Olympic guys.
I was going to say, in your world, I think that's what's so different is, we see little old lady grandma that wakes up with the crick in her neck and all that's great, but then what happens when you have your athlete or, in my case, baseball player, golfer with a bunch of neck pain and they need to compete,
Tomorrow.
Yeah, tomorrow. Today. Hey, dude, can I see you in like an hour?
And then you're just rummaging through the toolbox. You've tried everything that I know how to do.
Absolutely. Yeah, crush everything in that case.
So what do you think helped the most?
You're right. Who the hell knows? Does it feel better? Great. Good luck in competition. So I guess as a wrap up, what we're trying to say here is that you're going to educate your patient as to why we think it's, what's going on is going on, how we can change that and why we change that, do your manual therapy technique that we talked about, follow that with simple but very straightforward and effective exercises versus trying to make everything super complicated.
Yeah, I like to think of it as targeted too.
Yeah.
Because I think that's some pushback. We get sometimes as I get some patients who have tried a lot of corporate PT kind of things, and they're like,
Definitely.
I had 3 pages of exercises. It took me 3 hours to get through it. And I was like, okay, which ones do you think helped? Well, there was 1 or 2 that really helped. And I was like, okay, just do those.
Sure. Yeah.
And those are usually the ones that I would kind of use as my front line anyway.
Yeah. And if you look, you get your person back in the second visit. How you feeling? How's it going? What worked for you? It's not like, oh, hey, you did your sheet. You're going to be here for 6 to 8 weeks, and we'll just wait until you get better. It's
got plenty of time.
We
got
time
months.
For that. Just keep on knocking that sheet out,
months.
baby. So what helped for you? So that gives us more information because I can guarantee you that I'm going to change what we're going to do today based on last time.
We're
not just knocking the same thing out and building this huge sheet of wasted time in your case.
In fact, I think that's a good idea.
Yeah,
that's
absolutely.
A good idea.
It's better. All right. Anything else?
What were you talking about?
I don't know.
Okay.
I have no idea.
We're talking about how to convince people to get moving after an acute injury. And then I think we did something on pet peeves. We were talking about people who think that they need to rest completely before getting better.
That's right.
So using this, I think, is also a good way to educate/train patients
Yeah.
that, should this happen again, and with athletes, it will happen again
Yep.
on a long enough timeline, that, there's specific stuff they can do, which gives them more power and they don't feel hopeless. Like, oh, my back happened again.
Right.
Like, where they're very much, they're using language to distance themselves from their back.
Right.
They're both verbally talking about it, that it's belongs to someone else. It's not my back. It just happens all by itself.
Sure, and I think and when you understand that, hey, look, stuff comes up, little injuries happen, it can come up, but here, we know that that's going to happen, and that this is a way to problem solve it acutely, whether it's seeing somebody like us or, hey, look, if anything like this happens, here's education as to how you can best treat it very quickly, and then if you need to see us, you need to see us in the future.
Yeah.
So like you said, we're kind of building on what we've talked about previously in terms of the education side of things and how we treat, and why we treat how we treat, and then progressing that and specifically some case examples now. And then I think we're going to talk a little bit more in terms of some specific exercises, and as always, any questions from anybody out there in the internet world.
Actually, just thought of a really good question for you.
Ooh, let's hear it.
You got it? We got to do this now?
Yeah.
Okay. So, at a high enough intensity level, competitiveness, some injuries I don't want to say are inevitable, but they're high risk. They're
Ah.
high likelihood.
Mm-hmm.
So how do you educate particularly your younger baseball players and specifically pitchers
Yeah.
to be like, hey, you're gonna get some elbow issues, you're gonna
Yeah.
have some shoulder issues. Like, how do you decrease some of that fear avoidance? Because every young pitcher I've ever talked to is like, oh no, my elbow, my career in play is over.
Yeah, for sure.
So like, what's your process on that? Because that's your specialty.
It is indeed. Well, we have a conversation at some point relatively early, but like, look, you're trying to throw a baseball as hard as humanly possible, especially at the late high school to college level and certainly professional level. Once you throw something with an 8 in front of it, then you start to have a little bit more danger. That's just the way things go. Based on most of the research, if you throw harder, you're more likely to injure your elbow. But you know what? You also don't get a college scholarship, are competitive in high school, or play professional baseball by throwing a 72 mile an hour fastball. So ultimately, we've got to have that conversation, and we're going to try to reduce risk by doing some other stuff that we've talked about and we'll talk about. But what I also tell them is there's a difference between your elbow or your arm, shoulder. It's always shoulder or elbow. That's the way it goes. Sometimes low back. Soreness versus something I don't like. And soreness at the elbow is typically an issue with either having a hard, aggressive session, bullpen session, or game, versus, oh, hey, I'm a little sore. And maybe that's because we're just slowly and progressively building up arm strength. And so when they understand, like, oh, yeah, I'm just a little bit sore in there, it's all good, versus, whoa, I threw one pitch, which is typically what they'll come in saying, and I get this hot electric thing down my arm, or I feel this really strong sensation here locally. That usually sounds a little different, and they understand that, and then they come to me for a little assessment, or I need to send them out to go see somebody. So that to me is the big differentiator right there, is them understanding the difference between like soreness and something bad.
Yeah.
And
Triage and management.
Yeah, I mean, it can happen. So they
Triage
come
and
to see me.
management.
Well.
We got someone else showing up?
No.
Oh, okay.
No, just some little league guy. So
Oh,
no big deal.
whoa.
Yep.
Okay.
All right, next episode.
Next episode, as always, shameless self-promotion. Look us up. We're here as a resource for the community at large. If you think we know what we're talking about, which is highly suspect, let us know.
Absolutely. See you next time.